I'm Philip Saplinski, Jr., MD, and I'm going to be discussing black, white, and gray secrets of the abdominal X-ray. So why an abdominal X-ray? We have CT scans now. People always wonder why would we do an abdominal flat plate? So they're fast, they have less radiation than a CT scan, they can be done at the bedside, they can be used for bowel obstruction studies, and they're diagnostic for foreign objects within the abdomen, and we'll talk more about these. So first you want to get a complete history and physical exam. You want to know why you're ordering an abdominal X-ray for this person. Then there's different positions: supine, erect, and decubitus. Erect over supine, you'll have visualization of air fluid levels. Decubitus film, not quite as often used as it used to be, but essentially it can be used to visualize fluid levels within the large bowel. Normal anatomy, you can see solid organs, the liver edge, renal outlines. Here you can see faint outlines of the kidneys. Then you could also see the small bowel. You can see the valvulae. They're closer together and cross the width of the bowel. Maximal small bowel caliber is typically 3.5 centimeters of the jejunum, 2.5 of the ileum. And then large bowel, you'll be able to see feces in the large bowel, incomplete haustral bands. And then also the size, transverse colon is oftentimes 5.5 centimeters in diameter, and the cecal diameter is up to 9 centimeters. Normal variations in distribution of bowel gas. This is kind of a complicated image, but I like it particularly because you can see the haustra here in the large bowel. You can see that they don't completely connect, whereas you have the valvulae in the small bowel, and these transverse the full width of the bowel here. Also, normals that you'll see is fluid levels in the small bowel and fecal matter down here, particularly in the rectum. You'll see gray densities that'll change a little bit based on whether it's liquid, gas, or solids. So then also supine versus upright. This is the same individual laid down flat supine and then upright, and you would use the upright particularly for air fluid levels. So how to read, that's why we're doing this. You want to take a systematic approach whenever you're reading any X-ray, whether it be chest X-ray, pelvic X-ray, in this case abdominal X-ray. So you're going to look in the midline here, you can see the vertebrae, you look at the quality of the abdominal X-ray, and then what kind of bony structures are available here. You can see the vertebrae, you can see the ribs in each individual one here, you can see the pelvis, the femur. You want to work from medial to lateral bilaterally. And also, are you able to see organs? So it depends on what you're doing with the abdominal X-ray, but in this case here, you can see the faint outline of the liver. Here you can see the faint outline of the spleen. And then here you can see a faint outline of the kidneys, and there's some contrasts within the kidneys, so now you can see the ureter, and then also the bladder. Also look for abnormal calcifications, and we'll get a little bit more into bowel gas patterns. Gastric bubble, this is something that's a normal. So here's a normal right here. That's the stomach, and that's the splenic flexure. That's the gastric bubble. Here's a chest X-ray that shows that a little bit better. Here's an air fluid level within the stomach itself. But sometimes you have free air within the abdomen. We'll talk a little bit more of that, but here are some examples where you have normal, and then this would be abnormal. A little bit of air above the splenic flexure, or here bilaterally you have some air underneath the hemidiaphragms. Extraluminal gas, that's now where we're headed. Areas to search for abnormal extraluminal gas, you want to look underneath the diaphragm here bilaterally. We actually do have some air here. Then in the biliary system, and then you want to look within the bowel walls too if you're able to see it. And then in this case you can see that there's dilated small bowel, and we'll discuss that a little bit more because this person actually has a sigmoid carcinoma. We have the sickle-shaped free air under the right hemidiaphragm, and then small linear free air along the margin. It's a little difficult to see, but it does exist there. And then air distension of the jejunum, so now we have this small bowel obstruction with the transition area between dilated jejunum and normal ileum, and you can see that down here. Hollow viscous perforation, this is where you get your free air. So this is just more free air that I wanted to show. Right and left hemidiaphragm has free air underneath the diaphragm. And this is a lateral view of the same patient. You can see each individual diaphragm and the air that's underneath it. And then a CT scan that kind of shows what can happen with free air. It's now starting to track up through the aortic hiatus, and it's from a perforated diverticulitis. Is this free air? It's a little bit of a hazy image here, but this is above the liver, and when you look here, it looks like that there's free air. However, if you look very carefully at his haustra, and somebody did a CT scan just to prove it, and that haustra is actually Chilaiditi syndrome. This is essentially the large bowel, going over the top of the liver, and that will simulate what might be free air, but it's not in fact because of those haustra. Small bowel obstruction, oftentimes we start with a flat plate to see what we can see from that first. This is the image that we looked at earlier. When the patient is laying down supine, you can see that there's distended small bowel and that those valvulae are stretched out. So the loops of distended small bowel greater than 3 centimeters. If we measured this in a PAC system, we would see that it's greater than 3. Dilated bowel loops proximal and collapsed bowel loops distal to the obstruction. So if you look here, you can't see air within the larger bowel or in the rectum. And that's a clue that maybe we have a small bowel obstruction. We sit the person up and take another abdominal X-ray, and you get gas and air fluid levels. If you have greater than 3 air fluid levels on the erect radiograph, and it's measuring greater than 3 centimeters, you can pretty much assume that you're dealing with a small bowel obstruction. You can also see that there's no gas within the large bowel. And then also, in addition to that, the stretch sign, you look at the valvulae, and they're stretched out farther than they would normally be on a normal abdominal X-ray. So that's called the stretch sign. This is a complete small bowel obstruction. I use this one just to show that if you measure it, this is in fact 3.89, which is greater than our limit of 3 centimeters. And then also we hear this term paucity of air in the colon. And essentially that means that there is a lack of air within the colon and the rectum, which would normally be there, that we do not have in this, and that means that we likely have a complete small bowel obstruction. Volvulus. So when you look at the large bowel, in this particular case, we have a distension, and it's a little difficult to see here, but it's a distended large bowel greater than what we would expect for normal. And when you're getting up to sizes of 10 to 11 centimeters, that might be an indication that you might want to take this patient to the OR to avoid perforation of the bowel. Also, in some further imaging, I'll show you that there is what's called a kidney bean or a coffee bean sign that'll show up for these patients on an abdominal X-ray. I don't think that you can see it very well here, but you'll definitely see it on the next ones. In this particular patient, you have visible fecal material here within the right colon, which should not be expected typically. Left and right sigmoid colons aren't represented, so you can't see as you go around here where the large bowel should be. There's no air within the rectum. In the left lower quadrant, there's probably a mass here that's causing this obstruction of the large bowel. So this is the infamous coffee bean or kidney bean sign, and this in particular is called the Friedman-Dahl sign. If you can imagine this as a balloon that's twisted on itself, this is where the twist takes place. And so there are 3 points that come down exactly where that obstruction is now taking place. That's called the Friedman-Dahl sign. And this is the infamous kidney bean or coffee bean that we're looking for. You can also see it here too. This is now in the shape of a coffee bean. And then with the injected dye for a barium enema, you can see that it comes up and it comes to a point where that twist is probably taking place in the large bowel, and that's called the bird's beak sign. You can also use abdominal X-rays to find ingested objects, or if your patient is somewhat peritonitic and you can't quite figure out why. I thought this was a little fun. You can see here, this patient swallowed a toothbrush, and it shows up fairly well, at least on the bristles. And then this person's probably missing some silverware and some spare change, and I think we found it in the stomach and even in the rectum.